I'm not sure if they are around, but then I want to appreciate the presence of the CPAN experts, the CPAN specialty groups present, then the CPAN council members, and then CPAN chairman, Dr. Joseph Maji. Not sure he's online yet. And the desk officer for clinical oncology, Pharmacists of Nigeria, Dr. Rita Kuriji. I want to acknowledge your presence to our meeting this evening. May I humbly invite Dr. Rita Kuriji for our opening remarks. You're welcome, ma'am. Dr. Rita, can you hear me?
Oh, okay. Sorry, I just unmuted myself. Good evening, everyone. Good evening. I hope I'm audible enough.
Yes, you
Hello.
are.
Okay. So I want to join my voice with that of Oluwatosin to welcome everyone that is on this call to our first meeting for the year. Yes, it has taken some time for us to actually meet, but we thank God that it's possible tonight. And I sincerely want to also thank and acknowledge my Codex officer in the person of Dr. Adewale Adepoju. You're welcome, sir. And I sincerely thank you for making it possible for tonight's meeting, for accepting to give us today's clinical presentation, despite the very, 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 very short notice, sir. We appreciate you, sir. We say a very, very big thank you. And I must say that today is a meeting and the topic is really, really apt in the sense that the month of March is dedicated to awareness on colorectal cancer. And it's not really one of the major cancers, but with recent studies and some risk factors, it is gradually increasing in prevalence and incidence. And that's why we deem it fit today to actually educate ourselves on how we can be advocates in getting people to get themselves screened early enough and to prevent onset of the cancer. So that's why we felt it was necessary to enlighten ourselves as clinical pharmacists. And so without wasting much time, I promise that today's meeting is going to be as brief as possible. So I enjoin everyone to participate actively and listen. And when it's time for question and contribution, feel free to make our comments and our contribution. And then I thank everyone for joining today's clinical meeting. Thank you very much. Over to you, our dear uncle, Amoluwatosin. Thank you.
Thank you, Ma. Thanks for your opening remarks. Yes, just like she said, the meeting is going to be a very brief one and very, very fast. So without wasting our time, I would like to introduce our speaker this night briefly. Yes, he's a Dr. Adewale Adepoju, and he's a radio pharmacist and the Deputy Director of Pharmacy Services at the Radio Pharmacy Unit, Nuclear Medicine Department, University College Hospital, Ibadan. He's also a WAPCP certified oncology pharmacist. I must say that he's an experienced pharmacist and very knowledgeable in the field of oncology. And I want to assure you this evening that it will be worth your time listening to him, to his presentation this night. May I humbly invite Dr. Adewale Adepoju for his presentation this night. Thank you.
Sure.
Dr. Adewale, yes, sir.
Good evening, everybody. I hope I'm audible enough.
Yes, sir, you are.
All right, please, from time to time, I'll check with us because network is not so nice now. So I don't know. I may have been cut off at any time, but I would like to check with us if I'm still audible and so that I will not just be speaking to myself. So I want to appreciate the moderator and I want to stand on existing protocol to appreciate everyone that is on this meeting. Um, Tonight, as has been said, is going to be a brief one, but I'm very um, optimistic that it will worth our time, like has been said. What I'm going to do is to do an overview of what colorectal cancer was, is, and is becoming now. So I want to share my slide. Please let me know if you can see the slide.
Yes, sir, I can see the slide.
Okay, I'm trying to put it in there. Okay, I'm trying to put it in a presentation mode. So can you see it now?
It's bolder now. It's better.
Ah, all right. Okay, so I'll just go on now. I think I have 30 minutes and by 10 minutes to 9, I should stop. And I can even finish before that time. So we're talking about colorectal cancer, the rising scourge. That's my name and all that. So we move on to what the outline will be tonight. I'll be looking at some global statistics and some national statistics. You know, we don't keep records like that in the country, even in Africa. So it was not easy laying my hands on some national statistics about colorectal cancer. But at the end of the day, I got some, and it will make a lot of meaning. So we'll look at global and some national statistics to let us know that really colorectal cancer is becoming a rising scourge. And once I'm done with that, we'll move to the things we need to know, what we need to know as clinical pharmacists, as health professionals, what we need to know. And what will be my guide will be the WHO key facts. And once I'm done with that, I'll conclude. So I'll go on to my first slide. I'm talking about the global statistics. Colorectal cancer, as we know it, is a cancer of great burden. And if we don't know by now, we should know, because it's actually the third most common cancer in both men and women. And you can see from the chart I have here on the left side of your screen, the global cancer statistics as at 2020 from WHO. Colorectal cancer is actually 10% of all the cancers. Female breast cancer takes the first place, 11.7%. Lung cancer, 11.4%. Colorectal cancer is 10%. And we have all the rest: prostate, stomach, liver, esophagus, cervix, and all that. So colorectal cancer is actually a serious body. It's a cancer with a serious body on the world scene. So it's the third most common cancer in both men and women. And in 2020, the global cases actually stood at about 1.8 million people for colorectal cancer now. And we have like over 1.1 million. You can see the actual numbers: 1,148,515 for colon cancer, and over 730 1,000 rectal cases. So it's that much in the world. From 2011 to 2019, the incidence rates, talking globally, and when we talk globally, we talk about the Western world, really. That's where we have all the development and all that. So I'll be zeroing in on the US. So from 2011 to 2019, the incidence rates continued to decrease by 1% annually in the US. And you should know, developed country, they have the best of screening, they have the best of treatment, they have clinical trials going on there, they can use investigational drugs and all that. And so they're really handling it well. So there's a decrease of 1% annually in the US. However, the incidence has been on the rise by 1% to 2% yearly in younger people, in the younger population since the mid-1990s. And that's why it's becoming a serious scourge, because we now have less than 30 years old coming down with colorectal cancer. It's a disease that we believe over 50 years and above people have, but now we're seeing it in as low as below 30 years of age. So it's really becoming a concern. And it is estimated that by 2040, the burden of colorectal cancer will increase to like 3.2 million new cases per year. So compared to what we have now, that's about 63% increase in the new cases that will come up. And the mortality also will increase. It's estimated that 1.6 million deaths per year will be experienced by 2040. And 2040 is not far away, it's around the corner. And that mortality is 73% increase from what we have presently. And all these facts are from WHO. So really, even in the developed world, this scourge is rising. It's something that is worth looking into and curbing quickly. Okay. So let's look at the mortality now. Let's look at the death rates and all that, the death incidents and all that. You could see from the chart. Am I still audible, please?
Yes, sir.
All right. So you could see from the chart that colorectal cancer, and the source is GlobalCan, that is from WHO. So 2018, lung cancer takes the first place. Colorectal cancer actually is the second. So worldwide, colorectal cancer is the second leading cause of cancer death. And we can see the breakdown for others: stomach, liver cancer, breast cancer. I think we're having a very good hold on breast cancer. It's not killing like that. You can imagine colorectal cancer is killing more than breast cancer. Esophagus, pancreas, prostate, and all the rest. In 2020, an estimated 915,880 people died from colorectal cancer. And that's the breakdown from colon cancer, and those that died from rectal cancer. That's so much. A lot of people are dying yearly. In 2023, just last year, it was estimated in the US, that was an estimate for that time. So around 153,000 died last year. Adults died in the US of colorectal cancer. That's also the breakdown. Over 106,000 cases for colon cancer. We have over 44,000 men, over 52,000 women, and over 46,000 cases of people died from rectal cancer. And that's also the breakdown. So it's a real scourge, and it's rising. So let's look at the survival rate of colorectal cancer globally. Generally, there's a 5-year relative survival rate for all cancers. And that's what experts do. They do a 5-year relative survival rate. They look at when the disease is diagnosed and the treatment. Within 5 years, they want to see who survives and who dies. So what are the factors that affect survival rates? So we look at the factors, and these are the patient's age. Naturally, we know is meant to affect people over 50, but like I said, the age is dropping down. So the patient's age is really a factor. People who are above 50 are told to go do screening, but even now we encourage people lower than 50 to do screening so that this cancer can be picked at the early stage and addressed quickly. So the patient's age is a factor in calculating or determining who survives what and who does not survive. The stage of the cancer is also another factor. We know that a stage 1 cancer is curable, is a piece of cake to manage. But when it starts getting to stage 3, stage 4, because of the metastasis, distant metastasis and all that, affecting so many organs at the same time, it's not just worth treating anymore. So the prognosis at that time is bad. So the stage of the cancer determines if this patient will survive or if the patient will not survive. The patient's general health is also a factor. Patients who are very sickly or patients who have comorbid conditions don't do well, don't survive like patients who don't have comorbid conditions. Patients who have liver problems, kidney problems, and now come down with cancer that has spread distantly. That's a problem to treat. It's not easy. The survival rate of such would not be good. The rates will be so high. But if the patient's general health is good, then even if it's stage 2, stage 3, you can still manage, and then the patient will still come out and be successful with the treatment and all that. But when there are so many comorbid conditions, then it really is really a problem to treat and have success rates. And the last factor that affects survival rate is how well the treatment plan works. So if the treatment plan does not work well, then the patient may not survive. Maybe a patient should be placed on chemotherapy, or the patient should be placed on targeted therapies or maybe immunotherapy, and you place the patient on chemotherapy. The patient develops a lot of side effects and all that. That can curtail the life of the patient. So the survival rate for that patient or the survival index for that patient will drop. So how well the treatment plan works is also a factor that influence survival rate. It's still global stats. So let's look at the US. The 5-year relative survival rate for colorectal cancer that is just localized, that is in its localized stage. That means early stage is just at that point. It has not spread to any other part of the body. It has not spread to the lymph nodes. It has not spread to maybe other organs. So the survival rate is very high, you can see. That's 91%. Because for such cancers, since they are localized, surgery or maybe radiotherapy can take it out. And if biopsy has proved that it's not malignant, then it won't spread to any other part. So survival rate is quite high. Now look, if the cancer has now spread to surrounding tissues or organs, or it has spread to regional lymph nodes around, then the survival rate drops. You have 73%. If it has spread to distant part of the body, it has spread, and that means it has entered into the lymphatic system. There is lymph node involvement. It has spread far. It's gone to the liver, gone to the kidney, gone to the brain. You can see survival rate drops drastically to 14%. And about 22% of patients who are diagnosed at this stage have been recorded in the US. So if you have like 100 patients, 22% of them would be diagnosed at this stage where it has spread far and spread distantly. So there's not much you can do. 14% is not a good number. Okay. So let's go and let's just look at this is a colonoscopy of to show the stage. You can see stage 1 still small, is localized. It has not entered. It doesn't have any lymph node involvement. Stage 2, if it's having some lymph nodes involvement, then stage 3, it has gone to regional lymph nodes, has gone to other parts of the body, maybe surrounding organs. By stage 3, stage 4, it has spread distantly and to many organs, multiple organs, the brains, the liver, to everywhere. So this is just to show us the stages and to let us know how it affects survival rate. I'm not going to, we have said it's going to be a brief presentation. It's just to create awareness because this is colorectal cancer awareness month. So we want to create awareness. Let us know the basic things we need to know so that we can help other people prevent, and even those that are down with it can help them to get the right treatment. So let's look at, we're still on the survival rates. Let's look at colon versus rectal cancer in the US. So I'll be fast now. For colon cancer in the US, the overall 5-year relative survival rate is 63%. So it's localized and it has not spread to any lymph node or anywhere, then you have a 91% survival chance. If the cancer has spread to surrounding tissues, organs, and all that, it drops to 72%. If it has spread distantly to other parts of the body, it comes down to 13%. Let's see what that is with rectal cancer. The overall 5-year survival rate in the US is 68%. It's even better than colon cancer. If it's localized, it's still at the early stage, survival rate is 90%. That's good prognosis. Once it begins to spread lymph nodes and to surrounding tissues and organs, it goes down to 74%. And once it's spread distantly to other parts of the body, metastasis to multiple organs, the figure drops. You can see 17%. Okay, so now let's look at some national statistics because I can see my time is going, so I'll be very fast. For Nigeria, in the 1980s, am I still audible, please?
Yes, sir.
All right. In the 1980s, colorectal cancer incidence was just 18 patients annually all over the country. And some data were retrieved from the cancer registry in UCH Ibadan during the period of 2005 to 2009, which revealed an annual incidence of 50 to 70. Anyway, that shows that it's rising from 18 patients in the 80s. Now, 2005, 2009, it has risen to like 50 to 70 patients. The incidence right now, and in some sub-Saharan African country, has been found to be 4.04 out of every 100,000 population. 4.3 for men, 3.69 for women. However, that of Nigeria has been estimated to be 3.4 per 100,000 population. So by extrapolation, what we're saying is if we're looking at 200 million, we know we're more than 200 million in population. We'll be having like 6,800 cases. And that is a huge leap from just 50 to 70 that we had 2005, 2009. And I've put some of my references down here, but you still see the references at the end of the presentation. So this is a rising scourge, really. And it has also been reported that more than half of the patients die within 1 year of diagnosis in Nigeria now. This stat highlights the need for cost-effective, evidence-based prevention, screening, and treatment intervention. The research was done by AGO. I have the link in the reference at the end of the presentation. You'll see it. The report says that more than half of the patients who are diagnosed in a particular year die before when the year is over. So that's a serious scourge, and we need to look at it. And much more is that younger population are getting involved. They are coming down with colorectal cancer. Okay, colorectal cancer is so what do we need to know? We're done with the statistics. Let's look at what we need to know. As clinical pharmacists, as clinicians, we need to arm ourselves with information and to be able to help our patients, our friends, people who come around us for medical advice. They trust our judgment and all that. So colorectal cancer is a type of cancer that affects the colon. That's the large intestine, and the rectum, or the rectum. And it can cause serious harm and death. So the risk of colorectal cancer increases with age. I've said that. Most cases affect people over 50. Regular screening are crucial early detection. It has been found out that if colorectal cancer is detected early, there is most likely that it will still be a benign cancer. It will still just be localized. There will be no spread and all that. And quickly it can be attended to. So screening, and that is what the developed world have enjoyed. They do a lot of screening. There is what's it called? NHS, health insurance. People just walk into the hospital, do screenings and all that. So all these things are picked up when they are still at the early stage, where you can take it out immediately before it becomes something serious. Then common symptoms include diarrhea. The patient comes down with diarrhea, constipation, blood in the stool, very critical, abdominal pain, unexplained weight loss, fatigue. And if you check the iron levels, they are always very low, very low. And the risk of colorectal cancer can be reduced by eating healthy diet, staying physically active, no smoking here, no smoking of tobacco, no smoking of cigarettes and all that, and limiting alcohol. We know all these are risk factor for so many cancers, so many conditions. Ill health. Eat properly, healthy diet, staying physically active, not taking tobacco, not smoking cigarette, limiting alcohol. What other things do we need to know? Incidence rate of colorectal cancer have been decreasing in high-income countries, like I've said, largely as a result of effective screening programs. The prognosis for colorectal cancer varies depending on the stage of the diagnosis. I've said that. That's just re-emphasizing all that. Early stage cancers, like I've said, they have higher survival rates than advanced stage cancers. I've said that. Timely diagnosis, appropriate treatment, regular follow-up care are important for improving survival rates and quality of life. So we need to let our patients know, we need to let people come around us know that when they eat junks, when they don't eat healthily, and when they don't exercise as much as they should, they are kind of opening the door for colorectal cancer. Let's look at the risk factors for colorectal cancer. Like I've said, age, risk increases with age. 50 and above, risk increases. Personal history. Higher risk for individuals who have had colorectal cancer before, and or those that have certain polyps, or they've shown that they have mutations to maybe their GIT and all that, their rectum, their colon. So in diagnosis, we look out for all these polyps. We look out for mutations. I want to go into that, BRAS mutation, CRAS, and all that, but we won't go too far into all that. So personal history, very important. Lifestyle factors, talked about that. Unhealthy life factor choices, like diet high in processed meats. We should discourage people from doing this. Let people eat more fish. We know our country is not helping now. Fish is very expensive, but as much as possible, let's run away from processed meats. Let's run away from junk food, diets that are low in fruits and vegetables. We should take more of fruits and vegetables. We should avoid sedentary behavior, just sitting down for so long. Obesity, smoking, excessive alcohol consumption can increase this risk. And lastly, family history of a colorectal cancer. So if there's a family history, certain genetic conditions like this syndrome, Lynch syndrome, familial adenomatous polyposis, and all that can increase the risk, like any other cancer, anyway. How do we diagnose colorectal cancer? Physical examination can look at, through endoscopy, you can check, and even check the abdominal area to see if there's swelling and all that. Then you take it a step further, carry out imaging, and carry out abdominal ultrasound. CT scan will give a more anatomical representation, a more vivid anatomical representation. MRI too. Then examination of inside of the colon. This is very important, especially when you also want to get samples for biopsy. So you want to look at the inside through using colonoscopy and a sigmoidoscopy. This sigmoidoscopy looks at the lower part of the colon, while colonoscopy goes all the way to look at the whole length of the colon. So either of the two, especially if you know where it is localized, where the colorectal cancer or where the polyps, where the tumor is localized. So while examining, from this equipment, you can have some that can take a part of the tumor, take a part of the lesion you're seeing, bring it out, then carry out a biopsy, histological examination, histopathological examination to find out, is that tumor really cancerous? Is it a benign tumor? Is it a malignant one? Because all that will inform how we treat. The molecular testing to identify specific genetic mutations, I've talked about that, and biomarkers, but that's not for today. Because if there are those mutations, then treatment should take another form. You cannot just treat maybe a grade 1 cancer, like a low-grade cancer, like you treat a high-grade cancer and all that. So it's very important to do molecular testing, look at the genetic mutations and some biomarkers so that it can influence how we treat appropriately, because treating appropriately increases the survival rates. So how do we treat? We know all these approaches, treatment approaches, chemotherapy, using cytotoxic drugs and all that, with all their attendant side effects and all that. Surgery, targeted therapies, which will target only the cancer and leave the normal cells, as opposed to what chemotherapy will do, which will affect both the cancer cells and the normal cells. Immunotherapy, here when you use immune checkpoint blockers, you use monoclonal antibodies like you do with the targeted therapies, all in a bid to have treatment that is optimized and that would have less side effect, as the case may be. Then radiotherapy too. I know my time is almost up. I'm rushing now. Radiotherapy, where we use radiation to destroy the cancer cells. Okay, all right. I'm rounding up right now. So what's the moral of the story? Incident rates in developed clients are on the decline due to improved and increased levels of screening, treatment, while that of Africa and the West African sub-region on a steady rise. And you can see from the stats that we have reeled out, they're on a steady rise. That's why it's becoming a rising scourge. But more cause for alarm is the rise in the incidence of colorectal cancer in the young population, less than 40 years of age. There's also the problem of late presentation. We have it with almost all cancers. People present when it has spread to distant organs, when it has spread to surrounding regional lymph nodes and all that, which can take it far. And lifestyle challenges, which is characteristic of a nutrition transitional that we see, that people just have appetite for what comes from the West. And these are the things that are killing us. They are risk factors for colorectal cancer. And with this, we have decreased physical activities, which also lead to overweight and obesity, which are also risk factors for colorectal cancer. In the light of all this, it is imperative for all hands to be on deck to achieve increased screening. We need to encourage people to go for screening, because once it is picked up at the early stage, it can easily be treated with least amount of cost. And we can even have cost-effective and evidence-based prevention and treatment interventions that would achieve what the patient wants, the patient goals. Government, healthcare providers, support caregivers are all called upon to make sure that we achieve this, that we stem this rising scourge. Thank you. These are my references, and you will see some of the papers I've quoted within this the slides, so you can check them out. Thank you very much. That's the end of my presentation.
Thank you so much, Dr. Adewale, for your informative and enlightening presentation. Just a quick summary of the presentation. So he made us know that colorectal cancer is the third most common cancer in men and women all over the world, with about 10% prevalence. And it's the forecast by WHO is that by the year 2040, the burden of colorectal cancer will increase by 63%. And also, the mortality of colorectal cancer is the second leading cause of cancer deaths all over the world. Well, the survival rate also depends on the age, the age of the patient, the stage of the cancer, which makes early diagnosis a very important factor. And that's why we are having this enlightenment lecture. But in Nigeria, where we had, that was all over the world. In Nigeria, the icon is that within 1 year, 50% of those that are diagnosed with colorectal cancer ends up dying within the year, and 3.4% per 100,000 population. You know, that's really scary, because if the person is diagnosed at the beginning of the year, before the end of the year, the person dies, which is why we really need to increase our awareness on this particular cancer. Then the symptoms, we talked about the symptoms, which are usual, and the risk factors, and what can reduce the risk factors, which includes healthy diets, which is a common, a common factor. Then being physically active, and then no smoking, and the reduction in alcohol intake. So it's all timely diagnosis increases the survival rate of the colorectal cancer, and that is why we are having this lecture today. Once again, I want to say thank you, sir, for the enlightening and information presentation. Now we are on to questions and comments section. So if you have any question, comments, or clarifications, contributions, now is the time. You can please raise your hand so that I can. Thank you. Yes, sir. Group Captain Kayode Polami, sir. My Oga. You're welcome, sir.
Yeah, thank you very much. I hope I'm audible.
Yes, sir, you have.
Okay, yeah. Thank you very much for. I want to first commend the presenter and thank him for this enlightening lecture and presentation rather. I learned quite a lot this evening, and oncology pharmacy is one area that most of us, maybe I want to say, we are shying away from, or we don't have a lot of data in country. But with this presentation, I've actually learned so much, especially about this colorectal cancer. Looking at the global statistics and the national statistics is very scary, because when we get these informations, you start to look inwards and see what can we do. And I think the presenter pointed it out clearly that we need to create a lot of awareness. We need to create a lot of awareness and encourage people to go for screening so that it can be detected early, and also we can get better prognosis. So I think it's very important that we spread this good news and let people create awareness. Wherever we are, let's create awareness and let people, encourage people to go for screening, especially where people and above. But the scary part is that younger people now, less than 40, are now getting more into this colorectal cancer. So please, let's spread the message, create awareness, and encourage people to go for screening. I thank the presenter once again for this. He has actually whet our appetite so that we go and get more information and be on top of our game. I want to also commend the moderator for a job well done. She's from my constituency, so I have to specially recognize and thank her. So thank you very much for doing a good job. Thank you very much.
Thank you, sir. Thank you so much, sir. Any other person? Questions, contributions, comments? Okay. Okay. In the absence of any other contribution or questions, may I invite the guest officer to please give us the closing remarks? Dr. Rita.
Um, Thank you, everyone. I must commend our presenter for doing a great presentation tonight, enlightening us about the rising statistics of colorectal cancer. And as health professionals, we have a great task to go out there and sensitize people, raise the awareness to kind of bring down these alarming and threatening statistics that we have about colorectal cancer. I certainly want to thank everyone that have take the pain and sacrifice to join us for today's clinical meeting. We know recently we're having challenges with network, but you've taken the pain to try to connect with us today. We sincerely appreciate you all. And we also wish that you still be part of our subsequent presentation too. And to our uncle, pharmacist Oluwatosin Alade, we thank you so much for doing a great anchoring of our today's clinical meeting. We really appreciate you. And it's our prayers that everything we've learned today during this clinical meeting, and we are going as health professionals practice it and bring more people to the knowledge of colorectal cancer. So without wasting much time, I want to wish us all a good night rest and the very best of the week And to our Muslim brothers, happy Ramadan. Then to the Christians too, the very best of the Lenten season. Thank you all for joining us. Thank you.
Thank you, Ma, for the wonderful closing remarks. So we want to thank the Almighty God for the success of today's clinical meeting. And with this, we have come to the end of the clinical meeting. We thank everyone that has honored us with their presence, the CPON NESCO, CPON specialty groups, the council members, I don't think the chairman is around, and my senior colleagues, military colleagues, especially Group Captain Folani and every other person. We say thank you. We appreciate your presence. Thank you, everyone. Good night.
Good night, everyone.
Yeah.